MRD is a concept that is fundamental to oncology. In all honesty, it's been around for a century. You know, it used to be a patient would come in with a malignancy, and the size and extent and spread of that tumor would be assessed by physical exam. Shortly thereafter, you know, the concept of, at least in hematopoietic malignancies, of doing a bone marrow exam and staining a slide and counting blasts appeared. And that was a major advance, the sense that that's MRD, and then you could sort of make an intervention and repeat that test and see whether your intervention had made any difference. And that was done by counting the number of blasts to start with and the number of blasts after the intervention. You know, a lot of our standard terminology for complete remission or complete response of 5% or fewer blasts in the bone marrow comes from the fact that the sensitivity of a skilled hematopathologist to see a blast, you know, to count blasts in a stained slide was somewhere around 1 or 5%. But then techniques improved again. Flow cytometry, in terms of myeloma, serum paraprotein analysis. All of these techniques represented an advance in the accuracy and sensitivity and objectivity of measurable residual disease detection. And today, it's just that the methods have improved even more. So they are even more sensitive and more accurate and more standardized. And this is true of both nucleotide sequence-based approaches, and it's also true of flow cytometric approaches, and it's also true actually of serum paraprotein approaches. So to answer your question, I guess I would say, you know, to people who are saying, oh, but is MRD something that is ivory tower and new and different? My answer would be no. You're much smarter than you think. You're actually already doing it. All that has happened is that the tools that you can utilize to do it have just improved, you know, greatly, which gives you a much greater facility to really understand in great depth what's happening with your patient.